Welcome again to 10 Minutes with Harry. This is the third ECG talk on the interpretation of the normal pacemaker electrocardiogram. And today I'd like to talk about atrial pacing. This is single chamber atrial pacing, when we pace the heart without a ventricular lead. The electrocardiograph looks like this. You can see then it's unipolar, and in order to identify atrial pacing, we must see an atrial stimulus artifact, which is large. We must see a P wave that follows, and we have then an AV delay or PR interval. As we'll see in subsequent talks, the word AV delay means the timing from atrial pacing to ventricular pacing. And in this situation, we don't have ventricular pacing, and we have therefore ventricular sensing only, but I still call this a AV delay in preference to the PR interval. Single chamber atrial pacing, again, remember the three-letter code. The first letter is atrial pacing. The second letter is the chamber sensed, and whether it be in the atrium or no sensing. And the third letter is the actual response to sensing. It can be no or zero. It can be inhibited or triggered, similar to what we saw with ventricular pacing. Therefore, there are three types of single chamber atrial pacing. AOO, which is asynchronous, no sensing at all. And yes, we do use this in MRI patients temporarily in, of course, appropriate patients. AAI is inhibited and is by far the most commonly used single chamber atrial pacing. Whereas AAT, or triggered, means that when the P wave is sensed, the full energy of the pacemaker output is then into the P wave. And this is AAT, or triggered, and is very rarely indicated. Now let us look at some ECGs of atrial pacing. To the left, we can see that there is atrial sensing. This just looks like a normal PQRST, which of course it is. There's no evidence of pacing here. But to the right, in this patient, same Holter monitor, you can see atrial pacing when the heart rate became slower and it's 70 beats per minute. And once again, there is this stimulus artifact, P wave, and then an AV delay with a QRS and T wave. Atrial sensing and atrial pacing, and note the stimulus artifact. One of the things that's very hard for people to understand is that AAI pacing does not sense in the ventricle. So if you have ventricular ectopic beats, they are not sensed because the lead in the atrium can only sense in the atrium. So we have bizarre looking ECGs like this, and this again is unipolar. One can see atrial pacing with normal AV conduction, and then we have these two spikes going through the ventricular ectopics, and the first thing that one says is they're not sensed, and that's true. They aren't sensed because there is only a lead in the atrium. So we have two ventricular ectopics without retrograde conduction, and consequently are not sensed by the atrial channel. It's very important to remember that this is not pacemaker malfunction. Atrial triggered pacing is shown, and this is very rare ECG because we don't usually use this, but one can envisage this situation where the patient is pacemaker dependent on atrial pacing, and there's inappropriate sensing, And as a result of that, you programmed AAT. One can see the P wave, and toward the top of the P wave, one can see the small spike where the full output is placed into the P wave. In case there is inappropriate sensing, this would then pace, although at a faster rate than probably the sinus rate. Stimulus artifact is seen. The other thing about atrial pacing is people forget is that there are abnormalities in the atrium which may occur with atrial pacing. In this example here, you can see that there is a prolonged PR interval or AV delay, and there is a large bifid type P wave suggesting, of course, significant atrial abnormality, particularly on the left side. But this clearly takes a long time to depolarize the atrium, and one should recognize this as abnormal P wave, which happens to be with AAI pacing. The other concern is the prolonged AV delay. This is often done in order to encourage conduction to occur from the atrium to the ventricle in a normal manner. But as you can see here, the AV delay is approximately 400 milliseconds. It's long. And even at rest, one can see that the stimulus artifact occurs within the T wave of the previous beat. And what this means here is that a long AV delay, that at rest, the paced P wave lies at the end of the previous T wave. And in that way, the atrium will contract at the time when it is still ventricular systole, although at the end of it, and therefore the atrium contracts against closed AV valves, the mitral and tricuspid valve. This gives rise to a syndrome known as pacemaker syndrome and can be very symptomatic. Therefore, you can see in this example that atrial pacing is probably inappropriate, and that one should consider dual chamber pacing in this situation so as to shorten the AV delay and allow more physiologic type pacing. And finally, we have atrial paced Wenckebach AV block. Wenckebach AV block, particularly in the young, is a very common finding, particularly at nighttime, and therefore we have this block which is vagal. And you can see here that there is a long PR interval of 300 milliseconds. We have the drop beat, and then the next one is shorter at 260 milliseconds, which is a classic sequence, end of sequence and beginning of a next sequence of Wenckebach AV block. And this, of course, can occur with atrial pacing. The big concern here is that this patient is going to go into complete heart block. However, this can be physiologic, particularly overnight with the vagal influences, and therefore may not be as sinister as many people think. So what have I learned? There are 3 modes of single chamber atrial pacing. Despite a stimulus artifact, you can't always confirm atrial pacing on the ECG. And what I mean by that, you have to see the P wave before you can be sure about this. There is no ventricular sensing with single chamber atrial pacing. Single chamber atrial pacing may have a prolonged AV delay or Wenckebach block, and both of these are important to consider when using single chamber atrial pacing. And it may be better in these scenarios, though, to use dual chamber, or at least have a second lead available to be able to program dual chamber pacing when it is appropriate. Thank you.